Welcome to this video. Now today, again, for the second time, I'm so happy to spend some time with Dr. Adriana Garro. Dr. Garro, bonjour.
Bonjour. How are you?
Some French here. How are you doing?
I'm fine. Nice to be with you again.
Yeah, it's nice to have you again. We had a lot of views and comments on the first video we did together, talking about what you do guys at ClearTPS, and some of the questions, some of the comments people want to know. So if I send a case, how does it work? What do you do with that? Did you just put that in a computer and the computer does everything? And so I wanted to go with you, Dr. Garro, on all the process. So since I sent you a case and I want to know what you're doing with that case, how it works, and I'll let you go from here. And of course, give me the permission to ask you some questions.
Yeah, absolutely. So I'm going to go through your case with a little bit of the details of how the process works. Feel free to interrupt me. And as I always said, this is a great opportunity for learning, lots of things, not only from this case, but from the whole clear aligner process. So let's jump into it. And at Clear Treatment Planning Solutions, what we do is treatment plan the cases, as you know. And not everybody understands or is aware of what is the goal of a treatment planning service. And mainly it's just to achieve three things in a case. A case needs to be aesthetic, which is what the patient is looking for. It needs to be predictable as well, because we want to be able to achieve what we're planning. But it also needs to be stable. So whatever we're planning to provide this patient with an aesthetic result needs to be something with stability and that will hold long term. And the difference when you're using a treatment planning service is that it would always begin with an accurate diagnosis. So I'm going to challenge you today for not looking at teeth until we have really looked into the patient. We begin by understanding how is this patient malocclusion. Why does the patient have spaces, or why does the patient have crooked teeth? What caused this malocclusion? What are the underlying causes of this malocclusion? Because once you understand why your patient has certain situation, then you are empowered to make better decisions. And with these decisions, we do an optimized treatment plan. We change whatever movements need to be changed, and we communicate this seamlessly between the doctor and the technician, making it a very experience that is very fast, and it doesn't affect the process at all. What we can see here on the screen is what all clear aligner softwares do. And I think we commented on this last time. I really like this image because we need to understand as clinicians that softwares are great. Clear aligner softwares identify the mesial and distal surfaces of the teeth. The software identifies the center of the tooth, and the software knows preset arch forms and aligns or snap the teeth into an ideal position. But historically, doctors think that this is a treatment plan, and it is not. This is a setup, and a setup is the process done by the technicians with the Clear Aligner software. So what a treatment planning will be is, after having this first setup, making sure that you do a throughout evaluation of the clinical records. There are so many things that you will find on the records. First, you need to see what is the biotype of your patient. If your patient has a long face, if it has a square face, if the chin is postured backwards or forwards. How is the periodontal biotype of the patient? Is it thin? Is it thick? Can you make lots of movements towards the buccal or not? What is the type of malocclusion that the patient has? And is there any specific periodontal condition? Now, when you have evaluated these things, then you can start writing down what sort of options can you do. There could be different treatment planning options. There could be extraction versus IPR, could be distalization versus a vertical jump or an anterior posterior jump. There could be restorative options as well. And each different option is going to have pros and cons along with possible compromises. When you're doing this evaluation, you also need to know ahead of time if you will be needing auxiliary techniques and what is the best time to add them, or if you should wait till the end, or be prepared for what sort of buttons and elastics or tats you may need to finish this case. If anything comes up during the treatment, most of the time ahead of time when you do a treatment planning what are the most difficult movements that you may require to do some troubleshooting in the middle or at the end of the treatment. And of course, retention and finishing. What are the challenges of finishing this case? In all of this process, of course, it's done by the three people involved in the treatment planning. The technician at the C.L.E.A.R Aligner company plays a very important role because they are the ones that will use the software to set up the case initially. They have the ability to make sure the teeth are segmented in the appropriate way, to make sure the accesses are placed in the right position, make sure the scans are acceptable, the occlusion has been set the right way, that the gingiva is being cut in the right position. All of these things are in the hand of the technicians. Then the doctor, of course, is the one that begins the process and knows the patient. And hopefully what we try to do at ClearTPS is take away the majority of the time of this process, the majority of the clinical decisions and clinical evaluation of the case away from the hands of the doctor, so the doctor can use his time better and only do a final checkup on the case. So the process that you will go through when doing a case is very simple. The first thing you need to have is a case ready to be evaluated. This is an example of an Invisalign case, but it's no different from any other clear aligner software. So for this particular case, there needs to be already a setup created and ready to be evaluated. Then,
so that means, Dr. Garro, that means really to make it clear for you doctors is that you need to fill a prescription, you need to send the first prescription. It can be brief, but you need to send something and have a first ClinCheck coming back to you before we send it to ClearTPS, right?
Exactly.
Very
There
good.
needs to be a case ready to be reviewed. And
so you will not fill the prescription for the doctor?
No, we will not
That's
fill.
it.
Yeah.
Very good.
Mm-hmm. So once the doctor has filled the prescription and sent the initial instructions to the C.L.E.A.R Aligner company, a setup will be created. And this is where we can begin our process. This is where we start the optimization of the case. And the doctor needs to send us this order through our website. It's very simple to find at cleartps.com, and into my account, you'll be able to send the case. All you need to let us know is the patient ID, and then we'll start working on the case. And when the case is finished, usually within 3 to 5 business days, our cases are optimized. We will send you an email like this one that we sent you for the case. It's a very straightforward email, but it's going to contain a little bit of a diagnostic and general things that we found on the case, a few recommendations. And at this point, it's very important that the doctor feels comfortable when approving the case. It's always on the hand of the treating doctor, the final say if the case is right to be approved or if it needs further changes. What we see is that the majority of the time we provide a final ClinCheck that doctors are ready to be approved. But for some instances, doctors do, very few times they can do another modification or ask us for questions. And the idea is that we have saved the doctor a lot of time by doing most of the process. And if needed be that the doctor needs to do any additional changes, it's just minor.
That's it. That's one of the first thing. Another important thing is that first, you will not accept the case for the doctors, and that's really important. And that's for you doctors to do. I mean, don't think that ClearTPS will accept the case. This is not their job. This is not their responsibility. It is your responsibility to accept the case. The other thing, Dr. Garro, is that, like you said, most of the jobs, like 90% of the job is done. I want to do some simple modifications. I can do them myself, but let's say I'm not comfortable even doing these modifications. How does it work? Do I send it again to you? Do I write you an email?
Yeah, this email can be, as you say here at the end, it says, don't hesitate to reply to this email. So you can feel free to reply to this email. This is our main form of communication. And you can send it back saying, please change those attachments, or please add elastics, or give me a call, let's discuss this case, things like that. So always the doctor can feel free to reply to this email if there are questions or further modifications that you would like us to do.
And is this included in the service, or it's an additional service if I want to have that? How is it included in the case? How does it work?
It's included. It's included. The
Okay.
whole process.
Okay.
It's included within the fee.
Very good.
I want to say something before we move forward to the patient.
Yeah.
And it is the reason why a doctor will use a treatment planning service. And there are two reasons that I have found through the years. And the first reason is because the clinical knowledge and the clinical experience with clear aligners it's not that much, and the doctor is beginning the learning curve. So in that sort of situation, that first scenario, the treatment planning service is the best possible education tool, because the doctors will send us the cases. They will, have a review and an email for every single case. And the doctors will learn a lot from this process and getting, more confident to do more and more cases. Mm-hmm. And the second scenario why a doctor would want to use a treatment planning service is because the experience is so much and they are doing so great in the practice that they just don't have time to check these cases anymore, to do the back and forth communication with technicians and the back and forth modification process.
Because it is time consuming, and a lot of times we don't think of that. But yeah, if you start doing a lot of cases, you may spend less time at the chair, but you will have to spend a lot of time on the computer. And at one point, if you know that somebody can do it for you and can do it the same way you would do it, that becomes really interesting.
Yeah, and we see doctors sometimes reach a plateau in their growth because they feel this process is overwhelming. It's just taking a lot of time. And if the doctor is also doing other techniques, if it's also doing general dentistry and implants, and if it has a very broad practice, then it becomes even more of a challenge to find the time to do this. Yeah. Mm-hmm. So good. Let's jump into a case.
Let's jump to a case. Yes.
Let's do what we love the most, and
exactly
is checking our patients.
Yes.
And let's see. The first thing is, who do we have? What is this patient? Who is he? How old is he? So we have here very young Andrew. His name is Andrew. Very young patient, 21 years old. And I'm going to put out a challenge for you and all doctors watching this webinar, which is try not to look at the teeth until you have looked very deeply out.
That's so hard.
Everything else.
So hard to do.
So that's what we're going to do first. We're not going to look at Andrew's intraoral condition until we have really, really nailed down every single thing we can find in his extraoral images. So The treating doctor is the one that gets to know the patient, of course. So everything that you see on your patient, what is the main goal for the patient? What the patient's looking for? Is the patient having or showing any signs of a habit? Is the patient walking straight? All of these physical things that you can see from the patient when you have them in your office, make sure you do, and that you write them down, and make sure that you inform these conditions to your treatment planning services so we can have them when we're doing the evaluation. And then when we take these images and we do a more in-depth evaluation, the first thing that we look at is how is the harmony and the symmetry of the patient face. And let's take a look at Andrew as an example. We're going to analyze him today very deeply, and we can see that his facial thirds are very equilibrated, right?
Yeah.
Now, if we look at the line in the middle of his face that goes through the center of his eyebrows and the center of his nose, it should connect all the way down to the center of his chin, and the lips should be also in the middle of this line. But I'm seeing in this first photograph that Andrew's lips seem to be a little bit towards the right side.
Yeah.
So, I start wondering, could be that Andrew postured differently during the image, could be that his head is maybe not so straight. But I'm already writing down, there seems to be a little bit of an asymmetry in the lower facial third, okay? Now, if I look at Andrew smiling, the bipupillar line starts telling us if there is a more in-depth asymmetry on the upper facial third, and then the smile line will tell me if there is a cant. And it's very nice to see the difference between the repose image and the smiling image, because when there are maxillary discrepancies, they're more apparent in the smiling. So if a mandible is deviated, it's easier to see when they're smiling than where they are in repose. So see, and maybe in this image, Andrew doesn't have so much of an honest smile, because it's always difficult to get patients smiling honestly.
Yeah. Especially when they don't like their smile, when it's their chief complaint, that's it.
Yes, if they are not feeling confident about the way they smile, it's even more difficult, which is...
It's one of the fun thing of when you finish a case and you retake the final pictures and you see the difference in their smile, the difference in the eyes, the difference in their attitude is completely different.
It's completely different. So in this image, we see Andrew smiling, and it's more apparent that his chin, and even he has a little bit of hair on the chin, but we can see that we see more chin towards the right side than on the left side, right? So I'm already writing down that extraorally, in repose and smile, this patient seems to be having a facial asymmetry on the lower third. Now let's look at this patient's profile. And the profile image, if can be taken without any hair in the face. The less hair we have, the best, because it allows us to do a better analysis of the soft tissue. So here, with the true vertical line, we start defining if our patients have a flat profile, if they have a more convex or a concave profile. And of course, the ethnicity of the patient, different ethnicities have different characteristics that we know. In this, for example, for Andrew, we know that African American patients have a tendency to have more bimaxillary protrusion, so it is expected. But it's still, the true vertical line for any patient will tell us a little bit of the anterior posterior growth of the patient. Another important lines that will help us understand how the anterior posterior relationship of the maxillary bone was developed is the lines that will help us measure the maxillary and the mandibular. And here I have to say that an ideal scenario will be to have a cephalometric x-ray.
Yeah.
But if we don't, which is the majority of the case for clear aligners, the facial lines and the soft tissue analysis give us a very good guide of the different malocclusion characteristics of the patient. So here we
I have a question for you, because we take a ceph. We have to, and it's even the law here. We have no choice. We have to take a ceph for every case. It has to be traced before treatment and after treatment. So should we, if we have a ceph and a trace ceph, should we send this ceph to you before you do the?
If you haven't, we are very happy to receive it.
Oh, very good. Excellent.
Yes.
Very good. Perfect.
So,
because that's another difference, that if you can send it to Align when you send your case, but Align will not evaluate your ceph, will not evaluate your pan. This is not how it works. So if I include my ceph in my patient's file on the Invisalign doctor site, then you will have access to it when you do the treatment plan.
Exactly. We will have access to it. And remember, that's the difference between a clear aligner company and a treatment planning service like C.L.E.A.R.
That's it.
Because there are clinicians at C.L.E.A.R. evaluating and diagnosing your case.
Very good.
So another very fun line to drag on your patient profile image is the rickets line. And it tells us about the facial harmony and the position of the lips. And again, of course, the different ethnics have different characteristics, but it's very clear with the rickets line that the lower lip of Andrew is postured even more forward than the upper one. So remember, we have to remember our little list, right? And we haven't even looked at his teeth yet. We have the suspect of an asymmetry in the lower third. And now we have a lower lip and a mandible that seem to be more forward than he should be, right? So let's keep those things in mind as we move forward through the evaluation of Andrew. And when we do the soft tissue analysis, the nasolabial angulation is very important. Why is this? Because when we're doing the measurement of the nasolabial angle, we know how much can we retract, or we know if we are in the presence of a maxillary deficiency or maxillary growth that was not sufficient. And oftentimes we find patients with very open or flat nasolabial angle, and the doctors are trying to retract 3 millimeters just for the sake of decreasing the overjet, for example. And we need to remember, this is where people start showing their aging signs, right? The upper lip support is one of the first supports that we lose when we start aging. So the nasolabial angle is
Everything goes down, Adriana. Everything goes
down, but your nasolabial angle will go down first.
That's it.
Yeah. Then
the other thing they say is wrinkled skin, wrinkled teeth.
Well, yeah, that's a topic.
That's
a very interesting topic for another discussion.
Yeah.
What about the aging of the maxillary complex? What happens? What happens with your bones? And it's very interesting to see. But
we already have our next topic. That's good.
Absolutely. So with Andrew, when we do the mentolabial angle, we can see that it is a very that is an angle that he has. It's a very generous angle for him because of the characteristics of his lips. And for most of patients, we can have a better idea or a good idea of how the lower incisors are positioned within the mandibula when we look at this angle. And I say again, it's always better to have a cephalometric x-ray, but remember that the angle formed between the lower incisors and the mandibular plane tells you how much can you procline or retract the lower incisors.
Yeah.
And that's what forms this angle.
I have a question for you, Dr. Garro, is if the ceph tells you something and the face tells you something different, will you prefer to treat to the ceph or treat to the face?
That's a very good question. I think that soft tissues have become more important in the late years because patients are more concerned about the aesthetics or the way they look than doctors were before of achieving perfect cephalometric numbers. So it will be a combination of both, but the soft tissue will be probably the most important one.
I totally agree with you. I think that it's the time where we were only looking at the ceph. If my final ceph looks good, but the face doesn't look good, for me, it's not a success.
Yeah.
That's it. So we have to, at a certain point, yes, we look at the measures and everything, but you have to treat to the face. And that's it. This is, like you said, exactly like you said, patients are more concerned now about the look and everything. Yeah. And it becomes important.
Yeah, absolutely.
Very interesting. We still didn't look at the teeth.
Yeah, no teeth yet.
We don't even think about the teeth. You're so good.
This is the final image, and there is a facial axis, and the facial axis tells you about the vertical growth of your maxillary bones. Mm-hmm. Now, remember that the maxillary complex grows forwards and downwards. Right? That's how our face grows. It's from childhood to adulthood. Our face is growing, anteriorly and down. And the rotation of the mandible, it's a very important factor. When the mandible starts growing more than it should be, it can take a rotation towards the back. So the patient can become hyperdivergent. And when the patient has an hyperdivergent pattern, then we start facing open mites, gummy smiles that cannot be closed, or class 2 malocclusion caused by those hyperdivergencies. And looking at how this axis of the face is defined and how is this mandible growing, if it's too backwards, if it's too steep, or if it looks more harmonic, is very important. So
that becomes an issue, a big issue, if you're treating growing children. I mean, you have to be aware of that. You have to look at that, because it's not, I mean, when we're treating adults where the growth is finished, yeah, we know about it. But if you're treating children, you have to check these things. You have to know these things and be aware of these things. And they can have a big impact in your treatment and in the future of your patient.
Absolutely. And remember that if a kid is growing in a hyperdivergent way, it's going to keep growing that way. So you can fix an open mite and it's going to come back, because the biotype of the growth, the way the kid grows is not going to change.
And you know what they say about open bites? When you finish a case and everything's good, take your picture very fast. Final pictures very fast.
That is true.
Yeah, that's it. They can reopen very fast too. Mm-hmm.
That's true. So, as you can see, we haven't looked at his teeth yet, but we have a very good idea that something is off towards the right side on the front, and that may be an anterior-posterior issue with the lower anterior teeth. If you ask,
we have expectations now. We're expecting some things.
Yeah, and I'm suspecting Andrew has a little bit of a class 3-ish in him. But let's see what the teeth said now. Now I feel very comfortable that I can look at his teeth, and I know Andrew much better than I did 5 slides ago.
Yeah.
So now let's look at Andrew's teeth. And what do we find here? So Andrew, of course, he has a very healthy periodontal condition. He has class 1 on the right side and a class 3 on the left side. And this is because his mandible is deviated towards the right side. Okay? So we are facing here a midline discrepancy that is not a dental midline discrepancy, it's a skeletal midline discrepancy. Okay? Now we find spacing and we find an edge-to-edge bite. So we were right. He's a little bit of a class 3, isn't he? So now remember the ethnic characteristics are important, and diastemas in Afro-American patients are very common. They have a very strong soft tissue component, and it's very common to find this type of patients that don't want to close their diastemas.
Yeah.
Because it's a natural, characteristics. They have grown with them. They see them in their families. They want to keep them. But when the patients with these characteristics do want to close their diastemas, we need to note that the soft tissue component is strong. A very deep frenectomy will be required, and fixed retention will be required as well, because there's just going to have that tendency to keep opening, because it's part of the natural way that the Afro-American teeth and maxillary bones are configured. So that's another thing we see here. We see a little bit of a spacing in the lower arch as well. And now we are ready to start making some decisions. Now I'm going to jump outside the presentation because I want to show you the treatment planning sent by the doctor. So of course, what you write on your prescription form matters a lot to us as a treatment planning service provider. And based on this, we can have a little bit more of an understanding of what is the doctor expecting from the treatment. So we can see that the doctor wants to treat both arches. The doctor wants to treat all of the teeth. There is a limitation in regards where we can place attachments, which means there is a limitation on which teeth we can do certain movements. That means that if the movement needs an attachment, then we will have to remove it. This particular doctor wants to maintain the anterior-posterior relationship. It's not of a concern. The resulting overjet and overbite is to be shown, and the midline as well. Now we will also evaluate if the doctor has any specific preferences in regards IPR, expansion or proclination. We can see here that the doctor doesn't want to do IPR for this patient, or is not wishing to do IPR. And there are no more special instructions in this case. Now, when we look at this information, we will make a balanced decision of what of these treatment goals can be achieved, or of which ones we will need to change, and inform the doctor of the reason why. Does that make sense?
It makes sense. I have a question for you. Let's say I fill a prescription like this because I'm between two patients and I just want to go fast, and I know I'm going to send the case to you anyway. And I just want to receive a ClinCheck, from the line to be able to send it to you. Then when I send it to you, can I make more like special instructions to you about the case?
Absolutely. When you're sending a case to us, you can leave all the presets and just focus on the special instructions. Type down anything specific you want us to know.
Especially now that, when you do the comprehensive case with Invisalign, you have two options. You have the very fast prescription now, where it's almost 90% is filled already by a line, where you don't have any options. And for example, you cannot even put the special instructions.
Yeah.
So knowing I would send you guys the case, then I could just, fill it very fast and have the special instructions sent to you directly.
Absolutely, and you can also put, when you're sending the case to us in our account, in our dashboard at ClearTPS, you have a window to type down special instructions if you need to. So that's another way to let us know.
Is it? Do you have, like, you know, with aligning, we have these instructions. I don't remember how we call them. Those clinical preferences.
The clinical preference, yes.
Yes, clinical preference. Is it something we can have with you? Let's say I'm a regular client of you. I always send you cases. Is there, and do you at the point know my preferences and know that, for example, I never want any attachments on the second molars or things like that, or I prefer to use rectangular attachments instead of optimized attachment, that I don't have to repeat these things all the time?
Absolutely, absolutely. For Invisalign, I love their prescriptions because they always come with the clinical preferences attached at the bottom. So for Invisalign cases, it's very simple, but we know the profile of each one of our doctors. So the doctors using our service, the first time we do a case, we make a phone call to get to know the doctor, to capture any specific clinical preference that doctors have, and we keep them in storage. So we look at them every time that we're looking at a case from that particular doctor.
Very good.
So I'm going to show you now a little bit more about Andrew and what was done for him. So now we have seen all of his extraoral images. We have seen his intraoral images, and we know what the doctor is requesting. This is the initial setup created by Align Technology. We can see here is initial setup number 1. This one has 44 aligners. It has 38 stages plus a few passive aligner, which is the doctor preference. And let's play it and see what was developed for him. So what we see here, with the help of the superimposition, is that there is constriction occurring in the upper arch from third molar to third molar. The diastema is being closed. And in the mandibular arch, there seems to be happening some distalization of molars to improve the midline, to improve the edge-to-edge occlusion.
That's a very, very easy and predictable movement.
Yes.
Distalization of the 3 molars on that.
Yes, along with an extrusion of almost 1 millimeter with no attachment.
Yeah, exactly. But if it's happening on the ClinCheck, Adriana, it's because it's gonna happen in real life, right?
Yes, yes. So we also see a strange component of intermaxillary elastics on only one side of the arch. So we, of course, this is the initial ClinCheck, and remember, this is what we like to call a setup. This is not a treatment plan. It hasn't been evaluated properly by a clinician with an orthodontic knowledge, and we can comment lots of things about this initial setup, but let's just remember that it was done by the software with the assistance of a dental technician, and for that, it's very good. But if we apply all the knowledge that we have, we need to make a few changes. But before I go to those changes, let me show you how the occlusion is finishing on this patient. So in this initial ClinCheck plan, the patient is finishing with contacts in all of the anterior teeth. Okay? Now, I'm going to show you the optimized treatment plan. And this is the changes we created at C.L.E.A.R after the evaluation. This optimized ClinCheck plan only has 22 stages. So it's more than 10 stages less. And the reason for that is, number one, all the unnecessary movements have been removed. And number two, we have created a more predictable plan. What is happening now after the ClinCheck was optimized? So first of all, we are still closing the diastema, but we're not moving the third molars, which have very short clinical crowns, and we can't put attachments on them, so they don't need to be moved. In the lower arch, we are applying IPR sufficient to overcorrect the edge-to-edge occlusion. Why do we want to overcorrect the edge-to-edge occlusion? Because it's a class 3. And class 3 mandibles always keep going forward. So if you have a skeletal class 3 component, you always want to overcorrect. There is no contact on the anterior teeth, and we are actually getting 3 millimeters of overjet. These 3 millimeters of overjet are only on the computer and the initial completion of the case, probably. But down the years, we have some safe overjet for this young man to keep growing, right? Class 3 elastics are, of course, recommended. He has a class 3 component, but they need to be bilateral. We can't put elastics only on one side.
No, because it's a class 3. I mean, we have a class 3 subdivision. It's because of the shift of the mandible that it looks like a class 1 on one side and class 3, but it's a real class 3 on both sides. I mean, it's a skeletal class 3. That's it.
Exactly. We are correcting a class 3 malocclusion. That's what we have. Now, all the attachments that you see in this case are the part of the clinical preference from the doctor. So in this case, these are the C.L.E.A.R Institute attachment protocols. And doctors have different preferences in regard to attachments, and we follow them as required. In this case, we know that the closing of this diastema is going to be challenging. So we added vertical attachments, sash attachments.
With a very nice bevel, and that's it.
Very nice bevel with increased height to make sure we have a lot anchorage to close those central incisors. And as I said before, class 3, the majority of the IPR is being placed on the back, and because if we put a lot of IPR on the anterior teeth, they will have the tendency to retrocline. We will have the tendency to see them incline towards the lingual, and we don't want that. We want the force of the retraction to be applied here in the back. This retroclination of anterior teeth often causes terrible recessions in these lower incisors. So
and what I've seen, the worst cases I think I've seen, Adriana, of root resorption were in class 3 cases.
Yes, that's true, because you keep retracting and retracting, and there's a cortical bone down there in your mandible. So there's a limit. There's a biological limit of how much you could retract.
And you were talking when we started about that's the tissues and the periodontal tissues, and you should always palpate when you do your exam, when you do your initial exam with your patient. Always palpate with your finger. This is what we do. This is our instrument, and sometimes we forget about it. But go with your finger. You will feel. If you can feel all the roots, you feel it's really thin. And you're moving all the teeth like this. Think there's a root in there. There's a root in there, and you may have some limited movements that you can do. And if you feel these things, this is where you have to tell ClearTPS about these things, because they may have ideas with pictures, but the more information you can give them, the more they will give you a a treatment plan that is predictable for your case.
Yes, absolutely. And at the end, you, of course, you have with Invisalign the capability of seeing the images right next to your plan, which is very, very nice. But you can see that we've made lots of changes to this case to improve the predictability, to improve the long-term stability, to remove unnecessary movements, and we achieve a treatment with more than 10 stages. If we
in
do
less in less time.
In less time, it's actually it's 15 stages less.
15 stages less, and I guarantee you would do the case with the first setup, and you would do the case with this treatment plan, you would have completely different results.
Yes, absolutely. And instructions or recommendations for this case will be to make sure to plan for fixed retention, because in the upper arch, this diastema is going to want to come back.
This is a case, in fact, for myself, my preference would be to have both retention. I say sometimes suspenders and a belt, both.
Exactly.
You have the lingual wire and a vacuum form or an Invisalign retainer, Vivera, whatever, over it, because again, those spaces have a tendency to reopen very fast, and your patients, in a case like this, like Andrew, where the chief complaint is the space between the two front teeth. As soon as they feel a little bit that the space is coming back, and sometimes it can be even inside one day, they don't necessarily see it, but you can feel that they will not like that, you will not like that, so better prevent these collateral damages that we don't want to see.
Yeah, absolutely. And another important thing is that Andrew is young. We don't expect any more residual growth from him, but he's a very young adult. He's only 21 years old. So after putting the fixed retention on Andrew, you want to keep seeing him. This is the sort of patient that needs to know, you have a class 3 component, or you have a very strong mandible that may have the tendency to continue in a small, not just growth, but, in a small forward posturing during your adulthood life. Just don't get lost. Come back every year. Let's make sure your retainers are fine. I'm going to need to monitor you through the next 2-3 years to make sure that, this stability is there. And for this stability,
let's say Dr. Garro, that Andrew would be 17 and we finish his case at 17 or 18. Would you recommend wearing class 3 elastics with retainers at night until he's like 21?
Yes, that's a good recommendation, to add the component of the elastics until the growth has finalized. Absolutely.
This is what I did with my son.
Yeah, see, it's good. It's remembering.
It worked.
Yeah,
it
we
worked
need
with
to
him.
think teeth and think bone as well.
That's it.
Yeah.
Exactly. And like you said, monitor and see your patient every 6 months, every year, or whatever. But make sure and sometimes it's even easier. If you're a general dentist, a lot of times you have these patients in your practice. They come back for their regular checkup, and so take the time, scan them, take x-rays, take measures, take pictures, and just monitor your patient over time.
Exactly. And the reason why we left Andrew, we approved a ClinCheck with 3.1 overjet. There's a reasoning behind it. Maybe that's, not for all of our patients. We want to have 3 millimeters at the end, but certainly with someone with the characteristics of Andrew, we do want to have that safe zone.
Yeah. And what I saw with time doing clear aligners is that I almost always finish with an overjet that is less than what we see on the ClinCheck.
Yes,
And I think that, yeah, and I think that one of the problems we had past, because I started in 2004 with Invisalign, and you know, we always had, when we started, these posterior open bites, and we thought that it was because of the intrusion of the posterior, but most of the time it was that the anterior was so uprighted that we had anterior interferences. And this is why when I see something like this, like a 3 millimeters of overjet, on the ClinCheck, I like it. I have no problem with that.
Yeah, and then that's a great topic for another webinar.
Another, yeah, that's a fourth one.
Yeah, the biology of the TMJ, the biology of your condyle, the disc displacements, and we see the overjet that patients are finishing with. And you need to bear in mind that if the patient has an anterior crossbite or a very severe crowding or a class 2 division 2, there is a high chance that your disc is displaced and that your condyle it's in a very up and backwards position within your fossa. And as soon as you start allowing some room, creating some overjet, then the whole TMJ complex is going to fall down into a better or healthier position, which will change your overjet completely. And that's definitely a very fascinating topic.
That's a topic. I mean, we could talk about that, and we could. I mean, you know how passionate people are when we are starting to talk about TMJ and problems in occlusion, and you have all different schools of thought, and that would be really interesting to have a video on that.
Absolutely, absolutely. And
listen, that was amazing. That was an amazing presentation. Really, I really liked what you did with the case. And I can, you know, with the experience I have, I can see just that, like I told you, how predictable the treatment plan you did will be compared to the initial setup that was done by the computer.
Yes, and this is the process we do for every single case. You know, we train our clinicians to have all of these lines in mind, to never look at the teeth before you look at the images. And aesthetic is important, but it's not the most important thing. And when we're doing clear aligners, we can't allow the computer to fool our knowledge, because sometimes we get too stuck into, you know, what is that you're seeing on the computer. That midline needs to be perfect. You know, those contacts on the canines need to appear, and then we forget everything else. And it is like the double-edged sword that we find with the digital treatment plans.
Everything is possible on the ClinCheck. I can take a tooth there and bring it there if I want. It's not, but again, if you rely only on the computer, you're not a doctor anymore, you're a technician.
Exactly, absolutely. And as this image shows, down at the beach with a few rocks, aesthetic is there, but it needs to be balanced with the predictability and the stability. And the stability is probably the most important of the three, is the one that provides the balance between aesthetics and predictability. And this is what we all want in any dental treatment we do, whether it's a crown, whether it's a filling, or whether it's a complete surgery. You want it to, the result, you want it to stay long term. And for that, we need to begin thinking about balance.
Yeah, was that picture taken in your backyard in Costa Rica?
Well, I wish I could say it was, but it wasn't. But it could have very well been taken in my backyard.
Yeah, I could. Yeah, that's it. I was sure of that. I was sure of that. Well, Dr. Garro, Adriana, I mean, thank you so much again. That was really interesting. Really like what you do with what you did with the case and how you guys work. If you're interested in having these, the ClearTPS services, again, we will put all the links in the description below. Everything is there. You also have the possibility to have your first ClinCheck treatment plan for free, right?
Yes, there is one test for each one of our dentists.
Test. Oh, the test is on you guys. But the other thing, very important, is just look at how much, if you just took the time of listening to what Dr. Garro was saying, to look at the first setup, to look at what they did with the case, this is where you learn. This is when you look at this, you compare, you can see things, you can start understanding about mechanics, what needs to be done. And as you will learn more and more, you will understand more and more, everything will become more clear to you. And I think, you guys are doing a great job. Thank you again for being there today. It was really, again, a very interesting, amazing. I'm sure we're going to have some really interesting comments. Leave your comments below. If you have questions, don't hesitate. And I guess that's what we had for you today. Any last words before we go, Dr. Garro?
Well, I just want to say that, our service is there. We've been there for years. And we like what we do. I think it's necessary. It's needed. And if a doctor needs this service because it's early in the learning curve, then we're there. And if the service is required because you just have been growing so much, you don't have time to do this, the service is there. It is for sure a very, very valuable service, and we're very happy to do it.
Well, doing a business with you guys, I can say you guys are passionate and dedicated to what you're doing, and you're doing it really, really, really well. So again, thank you very much. It's not the last video we'll have together, and that's it. This is what we had for you today.
Stay safe.
Oh yes. Bye.
If you like this video, subscribe to the channel, give us the thumbs up, click on the bell. You will be notified every time we have a new video, at least once a week. Also, you can look at these videos, and don't forget to visit our website at theclearinstitute.com.